we had this respirologist talk for us last year about the RSV vaccine. We'll touch on it again, and then we'll have him talk to the flu vaccine and the pneumonia vaccination. So really important vaccinations for everybody's lung health. The recording will be available in a few days on the BC Lung YouTube channel. So any questions that we didn't touch on or we might have gone over too quickly because we're trying to save time, please feel free to access that as well and share with people that this resource is available for them. So now that the intro is done, let's actually get into our talk today, which is understanding your COPD. There you go. So we'll do an intro of ourselves. Hopefully you already know us, but it's always a nice refresher for those of you that may not know us. I'll let Alexa introduce herself first.
So hi everyone, my name is Alexa. If you don't know me, I have been part of this webinar series for the last 3 years with the lovely co-hosts here, Lindsay. I have been a respiratory therapist for just now. I work in Kamloops, BC. I've worked in a variety of different roles throughout the hospital and throughout the community. And now I am in a leadership role for the respiratory department here at Royal Inland Hospital. I am also the face behind all of your questions. If you're on our Better Breathers Facebook page, if you ask a question, I will jump on there and try to answer any of your respiratory questions. So hello to those that are looking to put a face behind my name. And yeah, like I mentioned, we've been doing this webinar series now for 3 years, and I got the pleasure to graduate with one of my dear friends, Lindsay, and I'm going to hand it over to her.
Thanks, Lex. So I think Alexa failed to mention how many areas she's worked in, and I've had the luxury of working in an acute care community, education with patients, training. We really enjoy what we do and we love educating people. That's why we do these series. We graduated from Thompson Rivers University, which is here in Kamloops, which is the only place within British Columbia that trains respiratory therapists. And I know I love RTs, so I hope you do too. And that is where I'm currently working as one of the instructors and educators for the future respiratory therapists. So today, the topic of COPD and understanding COPD is very broad because every single one of you is different. So Alexa and I tried to do our best to kind of consolidate the most common things that we're asked about and what we educate patients on. And then you can go deeper into what your specific condition is like with all of your tests and medications. So the 3 topics, really mainly 2, are we will talk about what COPD is, we'll define it, list the most common causes, talk about the impact of tobacco smoke, and then the different types of COPD. And then we will talk about the impact on the function of respiratory structures, the most common ones. So we'll talk about the muscles of breathing, and then we'll talk about what happens in the lungs, the most common changes. And then we'll do a quick summary review, and any questions that you have, we will do our best to answer. So if you want, if you have any questions, put them in the chat box or write them down. So then at the end, when we have time for questions, we can address them and you don't forget them, okay? Before we even get going, I want everybody to stop and think about this. Don't answer it, don't tell me, but think to yourself, what is COPD? What do you know about it? If you had to explain it to someone, how would you explain it? What do you know about it? What do you want to know about it? So hopefully you've got some questions in your head that we can try and answer with today's talk. Okay, awesome. So COPD, what does it really stand for? I say COPD, that doesn't make any sense to anybody, but what it stands for is chronic obstructive pulmonary disease. So if we break it down to try and make sense of it, chronic means that it's not going to go away, but we can manage your symptoms. So once you have it, but we can try and manage what you've got. The O for obstructive means that the changes that happen to your lungs makes your airways narrow and they can get floppy. When airways get floppy, when we try and breathe out, they can flop shut. If you can't breathe out because flop shut, then air gets stuck. The old air that you pulled all that wonderful oxygen from gets stuck in your lungs, and there's less space for new fresh air. That's why that sense of shortness of breath arises most commonly with COPD. P is for pulmonary. It affects both your lungs. It's not just one-sided. And disease means that there's a scale. You can range from very mild to very severe, and everybody's going to fall in some different spot on that scale. Okay. So the most common causes that we see, and there can be a ton more, but the most common causes that we see in patients, generally the causes will causing symptoms to arise after the age of 40, except one of the ones that I've listed here. The most common cause for developing COPD is a smoking history. It is responsible for between 80 to 90% of the cases that are diagnosed with COPD. There are other risk factors though. The first one I've listed is a genetic factor. This is one that you could have the healthiest lifestyle, and if you develop COPD, especially at a younger age, it's due to the lack of something called alpha-1 antitrypsin. You have a deficiency in it, it's just genetic. And so your lungs don't have this protective enzyme to negate the negative effects of inflammation. Multiple childhood viral infections cause the same thing: inflammation, destruction of nice elasticity of the airways. Any environmental exposure, think about your whole life. Did you live in a city that was very polluted? Did you live in a household with secondhand smoke? Did you heat your house with wood smoke or wood fire? Did you grow up in Ontario where apparently there were these beautiful pink fluffy mounds of asbestos that kids could trollop through because it was so fun, right? Occupational exposures, fumes, chemicals, fine particle dust. So where did you work, and did you have the protective gear you should have? And then the final one, we're going to touch on a wee bit, but it's chronic untreated asthma. They fall under the same umbrella. Alexa is going to talk about how that happens. But the single most effective way to slow the progression of COPD, if you are still currently smoking, is quitting. Okay. So quitting smoking, what is the impact of cigarettes or e-cigarettes? And we highlighted these two because of the common component, which is the tobacco smoke. We know cigarettes and e-cigarettes have a whole bunch of chemicals in there to make them burn faster or taste good, or et cetera, et cetera. The impact of inhaling this smoke is a paralysis of these airway cilia, these fine hairs that are supposed to clean your lungs out. And they do this lovely back and forth motion where they sweep that normal mucus up and out. And we normally clear out our lungs every day, right? It keeps them healthy. But if we inhale tobacco smoke in any form from a cigarette, what can happen is those cilia temporarily get paralyzed. And if you have a prolonged exposure from smoking every day for years, the chemicals in that smoke can actually damage and then destroy those cilia, removing them completely. If we don't have that ability to clear that mucus up and out, all that wet, goopy stuff stays deep down in our lungs. And keeping that deep down in our lungs, it's wet and it's dark. Bacteria and infectious particles love it. They're like, let's go have a party, a little discotheque. And so they multiply in there, causing an infection. And with any infection, you get chronic inflammation and damage to those airways. Damage to those airways means they're not as elastic, they don't stay nice and open for you to exhale, and they flop shut. And finally, deep down in the lungs, our poor alveoli can get destroyed. Thanks, guys. There we go. Meaning we have an irreversible loss of lung function. Okay.
All right, thanks, Lindsay. So Lindsay did a great job at introducing what is COPD. So let's dive into the different categories or different types. So some of these words you may be familiar to you. So different forms of COPD, we can have chronic bronchitis, emphysema, bronchiectasis, and like Lindsay mentioned, chronic untreated or unmanaged asthma can turn into COPD. So let's dive into each one of these. So chronic bronchitis. I want you to think back. Have you ever had bronchitis? What were your symptoms? I'm sure there was a lot of coughing involved. I'm sure there was a lot of mucus produced. And how did your breathing change? Probably experienced some shortness of breath. Now think of having that infection causing damage all the time, and that these are your symptoms all the time. That's what chronic bronchitis is. It's chronic inflammation and scarring of the inner lining of our airways, our bronchial tubes. This swelling and inflammation inside the airways decreases the room to be able to breathe in and out. So harder to get air in and out. And that's why these patients experience that shortness of breath feeling. Symptoms include, like I mentioned, if you ever had bronchitis, coughing, increased mucus production, frequent throat clearing, trying to bring that mucus up, shortness of breath, like I mentioned, because of that inflammation inside the airways, causing it harder for the breath to come in and out. So let's look a little bit more at that structure. So as you can see here on the left, where it says normal bronchi, that's inside of your airway. We have our airway lining, and then there's that nice lumen to be able to breathe in. And now let's look at the other side, the one that's on the right, where it's bronchitis. That lumen is a lot smaller. You can see there's inflammation, there's thickening of the walls, and in there you see all that yellow, that's that increased mucus. So if you were to choose what one you're going to want to breathe from, the normal bronchi, the bigger lumen, you'll be able to get more air in and out. So this is why these structural changes, these patients experience quite a bit of shortness of breath and a lot of coughing because they were trying to get that mucus out. Next one I want to talk about is emphysema. I'm sure a lot of you have heard of this term. Emphysema is a very common form of COPD, and it begins with the destruction of the air sacs, also known as alveoli. This damage to these air sacs is irreversible. And what the damage is it's holes that form at these little air sacs. These holes or damage impede the oxygen from coming into from our lungs into our blood, and us removing our waste product, which is CO2. So because we have this, it inhibits gas exchange from happening and results in quite a few symptoms, which we'll talk about in a second. So let's take a little bit closer look. So if you look at the top picture, you'll see that's a normal alveoli. We see these clusters. We see these clusters of alveoli together. And if you look at the bottom one, this is what an airway emphysema. There's going to be holes formed. And if you look at the difference in tissue, the top one is nice and pink. It's getting oxygenated. The bottom one isn't getting as well oxygenated. We're not getting that good gas exchange occurring.
Oh, just a reminder to mute yourself if you can.
On top of holes being formed at these alveoli or these air sacs, the lungs also lose their elasticity. So this is really important because elasticity helps keep it open. So symptoms for people with emphysema, they typically feel a lot of coughing symptoms, shortness of breath if we're not getting that good gas exchange. And what we really see is limited exercise tolerance. So feeling really short of breath by just doing the slightest increase in movement. Walking up your stairs makes you feel very short of breath. And some people experience weight loss. All right, let's dive into the next one. Bronchiectasis. So bronchiectasis are when these airways inside of our lungs become overstretched. And when they become overstretched, they form pockets. These pockets will collect mucus. Patients with bronchiectasis can experience coughing where they produce mucus up to 1 to 1.5 cups of mucus per day. So to put that in comparison, typically a normal amount of sputum or mucus that we produce in a day is about 100 mils. So normally if we're supposed to be coughing up 100 mils, these patients are coughing up over a cup to a cup and a half a day. So quite a bit more mucus production. So these patients typically are involved with working with a physiotherapist to really help learn how to get that mucus up and out so that we're not creating this breeding ground of bacteria and infection risk. All right, let's talk a little bit about asthma. So Lindsay mentioned that asthma that has gone untreated or not well managed can lead to COPD. So just like COPD, asthma is an airway disease that makes it hard to get the air in and out. The airways will overreact to irritants. So you breathe in an irritant, whether that be pollen, whether that be dander from a dog, or just exposure to a chemical can make their airways really tight. Inside the airway, what we see is increased swelling, inflammation. And now we have those tight muscles on the outside, increased inflammation and tightening. This makes our airways very narrow. So symptoms include wheezing, coughing, mucus production, chest tightness, all very similar common symptoms of what we see in COPD. And we see that because of all this, it will trap air in and result in feeling that shortness of breath. The difference between asthma and COPD is asthma, if we manage it with our medications, reduce getting exacerbations or flare-ups, it can be reversed. We can see, it not progress. However, if we do not manage those symptoms, if we constantly allow our asthma to be in flare-ups and we're constantly seeing these symptoms, we're allowing that inflammation to continue inside the airway, that results in scarring the inside of the airway. And that scarring is unfortunately not reversible. And that's where we see it lead into COPD.
A lot of information already, eh? Let's try and talk a bit about the impact on our respiratory structures, because it's really the lungs and the muscles that are negatively impacted by the causes of COPD, and that's why it results in the symptoms that we've already kind of highlighted. So I will talk to the respiratory muscles. Alexa will speak to what happens inside the lungs. Click ahead. Thank you. Has everyone heard of the diaphragm? Give me a head nod or a thumbs up. Heck yeah. Okay. We love the diaphragm. In this image, we've got the lungs that are bright pink, and then underneath, kind of tucked under the heart as well, is this orange structure that represents the diaphragm. This is the main muscle of respiration. Every single breath that you take every day, every moment of your life, 80% of the work of that is taken on by this muscle. It is meant to work hard. It is efficient, and it is just a glorious muscle. I think I like the diaphragm. I don't know. It separates your thorax, so your heart and your lungs, from your abdomen. And even though in the image it looks like it's one muscle, it's actually two separate hemidiaphragms or half diaphragms that work together. So as you breathe in and breathe out, they move together. Normally, when we breathe, on the next slide, thanks, Lex. The image shows what happens. Now, I want everybody to put their hand on their tummy. Rub your tummy and just take a nice breath in and out. What did your stomach do? Did it move out a little bit when you took a breath in and then returned? That is normal. So the diaphragm, when we take a breath in, is supposed to contract and get tighter and smaller, and it's going to pull down. It pulls down and pushes into your abdomen so that the lungs can get longer, and then it helps with the ribs being pulled up so they can get bigger. And we suck a breath in. I don't push a breath into you. We suck a breath in. On the next slide, it shows what our diaphragm is supposed to normally do on exhalation. Exhalation is passive. The diaphragm relaxes, returns to its normal position, and the air gets pushed out as the ribs relax as well. So that is normal. On the next slide, this is what happens commonly with COPD. We normally take a breath in and we take a breath out, and our diaphragm is nice and curved like it is on the left picture. With COPD, because of those narrow airways or the floppy airways, when we take a breath in, they get stretched open. We can suck air in, no problem. When we go to exhale, that floppiness flops shut, and it prevents us from exhaling all that air out. Trapping air in, so you may hear the terms air trapping or hyperinflation, meaning our lungs are hyperinflated. There's more air in there than should be when we exhale. Because the lungs get bigger, they're going to push down on the diaphragm, and it shows that in the right-hand picture. And pushing on the diaphragm can flatten it out, meaning that the diaphragm is not in its best position to work for every breath. When a muscle is not in the best position to work, it needs help. Next slide. Oh, which I'll do in the next slide. Part of the other physical changes that you'll see is when your lungs remain inflated, you're going to have a puffed chest. Everybody kind of take a little breath in and hold it and puff your chest out. You kind of get this big, I'm super strong look, right? Your chest is puffed out, and don't be scared of me. I'm a mama bear. But that is not a normal way for our ribs to be positioned. Having that excess air in our lungs not only pushes up down on the diaphragm, it keeps our ribs up more than they normally should be. So when we normally take a nice breath in, the ribs should move up and relax down, but they're already starting partially up. So there's less movement for them, meaning we don't have as effective movement of our lungs and breathing a breath in. The next slide are the accessory muscles to breathing. So do you remember how much the diaphragm did? About 80% of the work, right? So there's extra muscles. I'm not going to learn them all. There's too many, but there are extra muscles that help lift our ribs and help us breathe. Those are called the accessory muscles. The most common one you'll see are the ones that run down the sides of your neck. If you work really hard to breathe, you might see them kind of strain. Because the diaphragm in COPD is not as effective, we need to use those accessory muscles more. And they are not efficient muscles. They need more oxygen to do what the diaphragm could do. And if we use them more, they're going to get bigger. So using those accessory muscles will help us breathe if our diaphragm isn't in the right spot or we've got air trapping. But they can only work for so long before they tucker out. So we want to make sure that you are as optimized as you can. So those are the impacts to the respiratory muscles. I'm going to pass over to Lex for what happens in the lungs.
Awesome. Thanks, Lindsay. So let's dive into what does the inside of our airways look like? Let's start with the trachea. So the trachea, also known as the windpipe, this is the largest part of our airway. And you can think of it being about the size of a garden hose. It then branches into two bronchi, which lead to both the left and the right lung. Think of these about the size of straws. Now it continues to divide and branch off 23 times until it reaches our smallest parts of our airways. And when it gets to the very bottom of that, they're about the size of a thread. So you can see how our airway goes from a large garden hose all the way down to a teeny tiny thread. So they keep branching and branching and branching till we get to the bronchioles. These inside of our airways, these bronchioles, have now a lining of muscles around them and an inner lining. And we're going to dive into what the inner lining looks like first. Oh, that's fast.
It
so
is fast.
You may have heard Lindsay talking about these little cilia or these tiny hairs that beat in they're not as fast. They're more of a rhythmic motion. And what they do is, so our airways are lined with the delicate membranes, and they have these little hair cells that help pulse and beat in the same rhythmic motion. And what their job is to do is to beat together to collect the dirt, bacteria, any pollution, anything foreign from our airways. They want to get that up and out of our mouth, or up and out of our lungs, or into our mouth, whether we cough it out or we subconsciously swallow it into our stomach. You'll also see that inside the lining of the airways, we also have these mucus glands, which are very important for our airways. Mucus, think of it being like the glue inside of our airways. They're going to capture all the bacteria and everything, and then these hairs going to help sweep it up and out. They keep these two things, the mucus and the cilia, keep the inside of our airways healthy. We want to keep it nice and healthy in there. But like Lindsay mentioned earlier on in the presentation, cigarette smoke or e-cigarette smoke actually paralyzes these tiny little cilia. So if you take a breath or an inhale of a cigarette or e-cigarette, it paralyzes the cilia for around 24, sometimes up to 48 hours. And now you just allowed a breeding ground for this bacteria to grow. Bacteria love living on moist things, so mucus, in my dark, well-humidified airways. So it's a breeding ground for the bacteria, and that's how infections. So when Lindsay mentioned that smoking is one of the most effective ways to help reduce COPD, it's going to help reduce getting those infections, which causes exacerbation. So super important point. All right. I talked also about that the airways have these muscles around them. So airway muscles normally function to maintain patency of these small to medium airways. They relax and tighten to allow our breath to come in and out, also to tighten to prevent any foreign material to get in our lungs. Now, when they tighten, they narrow the airway. So if you narrow the airway, you're not going to get as much air in, so you're going to feel that shortness of breath. With COPD, it kind of it chronically damages these, and that's what results in these floppy airways. Like Lindsay mentioned, when we have floppy airways, because these muscles aren't working strong enough, when we breathe out, they tend to close our airways sooner than getting all that air out. So then air traps in. So super important point that we want to make sure that we keep these airways nice and open so that we're not trapping that air. All right. When I talked about how our airways went from a garden hose, they branched into two, and they continued branching till they were the size of teeny tiny threads. At the very end of that are these airway sacs. So think of them like grape-like clusters. They're called our alveoli. This is the most delicate part of our airways. We have over 300 million alveoli in our airways. And to put that in perspective, if you were to take them all out and flatten them all out, they would be around the surface area of a tennis court. So a huge surface area tucked inside of our lungs. Why do I bring that up? Well, the importance of these is that this is where gas exchange happens. They have thin walls that allow what air that we breathe in, the oxygen, to cross over. And what wraps around them is our blood vessels and allows it to go into our blood to take it to our body where it needs it, our heart, our brain, our muscles. It also allows the blood to empty the waste product, or CO2, into the alveoli so that we breathe out that CO2 and it doesn't stay in our body. So super important for gas exchange. So like I mentioned, as we breathe in, that oxygen comes in into our windpipe, those branches in 23 times till it gets those clusters of alveoli, crosses into our blood, and our body says, take the waste product, all the way back out, we breathed it out. But like I mentioned in previous slides, these alveoli, especially in emphysema, can be damaged. And then that's where we have that inefficiency of these two things, getting oxygen in and CO2 out. So in summary, we talked about a lot.
There's a lot of information.
A lot of information. So some of the things that we talked about are symptoms of COPD. So common symptoms, what we talked about was there's probably going to be a cough, whether that be productive or you're bringing up mucus, or you can have a non-productive, meaning it's just a dry cough that's just constantly there. You may or may not have mucus production. It could be constant or it could be absent. You may experience shortness of breath, or maybe you only experience shortness of breath when you're going upstairs or you're exerting yourself. Everyone's going to have different levels of these symptoms. We talked about how it's progressive. So COPD develops and it slowly worsens over time. However, if we optimize our lung health, we manage our symptoms, we try to prevent these exacerbations, we quit smoking, we can prevent COPD from worsening so that you can maintain those activities of daily living. It is permanent, so we cannot reverse COPD. Like I mentioned with asthma, it's reversible if we really manage those symptoms, we prevent that inflammation. COPD is not reversible. However, we can reduce the symptoms, we can treat that, and we can also prevent it from getting worse. So this slide I find is very important because everyone with COPD is going to have a different, what we call normal. So you may have a normal dry cough. That's normal for your COPD. It's super important to know your baseline symptoms because if they change, so you would normally have a dry cough, but now you're starting to cough up mucus, that is the first trigger point to saying, hey, I might be having a flare-up. So get in tune to what your body, what your normal is. And if it starts to be, I'm starting to notice that I never used to be short of breath when I walk up the stairs, but now I'm huffing and puffing now. That is something that's going to alert you to have to start your action plan. Or if you don't have one, alert your physician or your primary care provider right away because something is changing with your COPD. All right, I think we talked a lot about COPD.
I think we talked a lot.
A lot of information. We're going to now put it over to you guys. We're going to first check the comments to see if there's any questions in the comments. And then if there's not, feel free to unmute yourself and we're here to answer questions.
Say your name so we know who we're talking to, and then we'll try and answer the questions. We still have a bit of time. The floor is yours.
Barry Beardso.
Hi.
Could you tell me what the difference is when you have COPD you're taking the puffers, they don't do any good, and then they put you on oxygen.
I think I'll start it and then I'll let Alexa jump in. So depending on where your COPD is and exactly what your diagnosis is, if it's a combination of COPD and asthma, puffers are great to try and optimize your breathing as much as possible. But depending on the severity of your COPD and what type of COPD, the oxygen exchange or gas exchange that Alexa spoke to could be impaired. That's why you need the oxygen.
Yeah, so whenever I talked about the alveoli and they form holes, that's a part going to be where that gas exchange occurs. And if we're not getting good gas exchange, then they give you oxygen to kind of make sure that you're getting enough going to your body because your body's not getting enough of that exchange going into your blood. For the puffers, there's still that ability to optimize. There's so many puffers. Like I think Lindsay and I mentioned this or had this talk back in February or March.
There's too many.
There's so many puffers on the market, and sometimes it takes a bit of trial and error to find what works best. And also, everybody's going to be different with their coverage. And unfortunately, sometimes there's some hoops that we have to go to be able to get you the right puffer. But you know how I talked about there's smooth muscle on the outside? There's some parts of those puffers going to help relax that muscle so that the airway stays open and doesn't flop too soon so that we can get that good gas exchange. And then parts of the puffer, which will be the inhaled steroids, is going to work on reducing that inflammation inside of the airway. So super important to still be on the puffer. We just got to make sure we find the right one that's going to be the best for you and where you're at. So I'm assuming that you would have got a blood test to see that your oxygen level was a little bit low. So that's why they put you on the oxygen. And then they're going to start looking at like, how are we going to manage your symptoms with being on the appropriate puffers for you?
Okay,
And
thank you.
Add to that really quickly. Not everybody needs oxygen. I think something that I commonly see in my practice, and Alexa may agree or not, that shortness of breath feeling can be improved with air flowing in. You know, having a fan on your face. And a lot of patients, if they come into hospital and stay a few nights, they get put on oxygen and they feel better. And then we say you don't need it. It's because their oxygen is moving into their blood properly. They just need it. They like the feel of air flowing on their face. But if you're on the oxygen, it's an appropriate add-on to your therapy, if I can say it that way. And your physicians, whoever's looking after you, is doing a good job to make sure that your oxygen levels are at a safe spot and your organs are getting what they need. If that
Thank
you.
Yeah. Hi, I'm Steph Nathan, and I've been on the same meds for many, many years. How do I know that they're still working, and how do I know that they're the best meds for me?
I love this question. I feel like we get this a lot. So first of all, what to know if you are on proper meds or if the medications that you're on, do you get any symptoms? Like when you go out, are you feeling shortness of breath? Are you coughing all the time? Do you feel that you're experiencing those symptoms still?
No, I'm doing better than I've ever done.
Well, that's amazing. So I think how I like to relate this is to kind of the cardiac medications. If you're experiencing like high blood pressure and your physician puts you on cardiac medication, it brings your blood pressure down. You're doing great. You're feeling great. That's the same thing as breathing medications. If you're feeling great and you're not having symptoms, that means you have the puffers that are meant for you and that you're on the right ones. If you start feeling symptoms of shortness of breath, coughing, that's how you know something's changed or the puffers that you're on are probably not the right ones. So if you're feeling symptom free and you're able to go out, exercise and do the things of, you know, your daily life, feeling symptom free, you're on the right medication.
Okay. I have another problem. I have arthritis in my hands and I can't work one of the puffers.
Okay.
So we've been trying to figure out another puffer or substitute and haven't been able to find it.
That's causing that you're having a hard time like using to depress it.
Yeah.
Is it the MDI, the shake and then puff down?
Yeah.
And that's too much. There are other devices.
There are. What color is it that you have that you're having a hard time?
The blue teal colored one.
Yeah, so what you could ask, because there's a lot of new puffers on the market that have medications combined. So depending on what you are taking, there's different devices where all you have to do is twist and push a button and it sprays in. So depending on what I'm assuming you're probably on Ventolin, like a blue one. Are you on a blue one, an orange one?
Purple.
Purple. So Advair. Is it a disc?
No, it's the pump. So
And
it's Advair.
You're having a hard time pressing that down?
Yeah. The purple one I can do, the other one I can't.
The bluish one?
Yeah, sometimes
Yeah.
some of the depressors are easier to use than the other.
You just have to talk to your healthcare provider and say, I'm having issues with that. And you can get that same medication in a different form, a different device that will be easier for you to use.
Yes.
Or sometimes I know some people, it's hard to get into their family care provider. Use your pharmacy. Your pharmacy will also be able to say, you know, either because you can't actually get like depressant, you need assistance with it. They can suggest and make that decision too. So I'd also suggest reaching out if you can't get in. Like I know some people can't get in their family doctor for weeks, so feel free to stop in to any pharmacy and they can be able to take that a look for you.
So that's great to hear that your symptoms are being managed. Like, be happy with that stuff. That's great.
I am. I was walking 7 kilometers a day on holidays.
Well, I don't even do that, so you can go away.
I'm just so thrilled.
Awesome. We're so happy to hear that. We're going to jump to the comments because we've got some questions popped into there. So we'll start with Elaine. So her question is, so the way to slow down the progression is to maintain lung health. Aside from the usual, get enough sleep, exercise, eat healthy, get vaccinated, use masks in public in cold and flu season, and use whatever medications have been prescribed. Is there anything else we can do? I think the one thing else I would add to that great list that you summarized there is just knowing your triggers and knowing like how can we avoid a flare-up? Because a flare-up or an exacerbation is what's going to cause your COPD to worsen and progress. So if, like you mentioned, staying away from people when they're sick or wearing a mask during cold and flu season, super good point. If you know things like heat, smoke, like right now we're going into extreme heat and wildfire season, does that cause you a flare up? Think about ways of how you're going to keep your home safe from the smoke coming in and the ways that you're going to be able to exercise indoors because outside is not going to be safe. If perfumes bug you, so just knowing what your triggers are, what makes you cough or what triggers your COPD so that you can prevent going into an exacerbation is going to be a key. And then if you don't panic if you do, get this flare up or you start noticing, hey, I have a dry cough and now I'm starting to bring up mucus. Early activation of your action plan is going to be key to prevent yourself from going into a flare up. So you and your physician, if you don't have an action plan, this is a great time to make an appointment with your physician because an action plan is a plan between you and your family care provider to state when you're going to maybe start taking a bit more of your medication or start an antibiotic or start some prednisone to prevent you from going for a full lung flare up. If you can start it early, we can prevent all that inflammation starting inside your lungs and hopefully prevent any scarring. So I hope that answers your question.
And this actually leads really nicely into the next question that was put in the chat by Erica, where she asked, you mentioned a plan and your doctor has not done one yet. So Erica, it's an asthma or COPD action plan. They are usually on the BC government website. And so what it is it's you working through it to recognize green, yellow, and red zone. Green zone, where is everything perfect? What is your best baseline where you feel the best? Yellow is when you start noting changes to that. And Alexa mentioned that in the last question where you normally don't cough and now you have a cough. Or you do normally cough, but you don't normally bring anything up and now you're bringing up some mucus. So that's where you would list the changes there. It's a nice visual kind of reminder that, hey, that I'm not in my green zone, something's happening. And usually when you're in that yellow zone, your physician will have a prescription for an antibiotic and a steroid on file at your pharmacy so that you can start that medication as soon as you can to avoid whatever is happening in your lungs, usually an infection, from really progressing and getting quite bad. The red zone is, hey, you're in trouble, you need to get in to see your healthcare provider ASAP or end up in the emergency department to try and manage and limit the damage that a lung infection can do to your already impaired lung function. So you can do that with your physician. You can do a lot of the work beforehand, especially if your physician is leaving. You could fill it out with your family so they're aware of it and they can remind you like, hey, we noticed that, your breathing has changed. And you go, oh, I didn't realize that I was just compensating. And then your physician can be the one to sign off and also to have the prescription sent to your pharmacy.
If you don't have an action plan, just note when you do go make what's it called, an appointment with your family care provider, please let them know that that's what you're wanting, because they do book the appointments a little bit longer. It takes a little bit longer for them to write it up, and they just want to make sure that you guys fully understand it. That also leads into a point that I wanted to bring up is we actually did a presentation on this not too long ago. So if you go back into our library of our webinar series on YouTube, the Experts webinar series, you actually can see, and there's one that will be labeled action plan. So if you don't know what we're talking about or you want to learn more, go and take a listen. It's about a 30-minute presentation with lots of great questions on that too.
Yeah.
I think Jacqueline was one of our ones that presented, or someone, Tracy presented, and it was excellent. So if you have any questions, definitely go back and take a listen to that.
But that's a really good question, because a lot of people don't have one or don't even know that they should have one. And if that can save you from getting sicker or having to go to the hospital, where, let's be honest, sick people go to the hospital. You don't want to be around those people.
And a lot of times you're waiting in an emergency for multiple hours. If you can manage at home, why wouldn't you? When you have a plan, that's the exact same medication they're going to give you in emerge. Let's just go to our pharmacy, get it, go home, be comfortable, stay away from the sick people in the hospital. So it's a great plan to have. And then you feel in control, like your symptoms. And if you can nip it in the bud from getting to a full flare-up, you just saved yourself from your lungs deteriorating. And I think that kind of leads into the next question by Elaine. So her question was, can you please send the visuals of your presentation to us? We record our presentation, and then in the next couple of days, it will be available on our YouTube channel. Again, just type into Google or YouTube, Ask the Experts, and you will see our faces, our logo, and you'll just go and find what today's topic is understanding your COPD. I also posted, if you're not already, but the Better Breathers Facebook page is a closed group where people with COPD, asthma, or any type of lung condition are on there to ask their questions. I always post it once it's available so that people can listen to the recording.
Irene had a question. Is there any research between statin drugs and muscle deterioration? Oh my gosh, I'm not gonna say the word.
Deterioration.
Thank you. So the literature is fairly new. There was a study or a paper that just came out this year that isn't really that informative, unfortunately. It shows that it can impact muscle cells and fibers, but it hasn't said that the diaphragm is negatively impacted at this point. We could have more information as studies come out, but there was no clear correlation with being on a statin, which is for high cholesterol, and the development of COPD, if that's where you were kind of thinking. But it's an interesting topic, and I'll definitely keep my eye out for more papers. And Kelly, thank you for letting Elaine know that the presentation is recorded.
Yes, thank you, Kelly.
Yeah.
The next question by Carl. Okay, what medication is available to reduce production of mucus?
So we don't want to reduce the production of mucus completely because we need it to keep our lungs moist. Like, lungs are these wet, glorious pink organs. I love them so much. So we need our mucus. If we have an infection and we are sick, mucus production increases for that time because our body's immune system is fighting off whatever's infecting us. And so this may sound terrible, but I love mucus, you guys. My students know this too. But the mucus that we have, we're creating more mucus, the goblet cells and mucus cells that create them, but it's also it is also the remains of the bacteria that our immune system have destroyed, which is a good thing. So if we're sick and we have an increase in mucus production just for that window, that is fine. It's better up and out than keeping it in. There are medications to help with the clearance of mucus production, but there's nothing to definitively decrease the production. Decreasing production would be antibiotics if it was a bacterial infection, right? Viral infections don't create mucus or an increase in mucus. It's the bacterial infection that follows a viral infection. If you are a patient that has chronic amounts of mucus production, patients with cystic fibrosis, they have very thick, tenacious, sticky mucus that they cannot cough and clear. They can take medications, but when we use medications to help break up mucus and clear it, it is usually the last option.
We probably want to think of more bronchial hygiene,
Mobility.
positioning. So if you're finding like you've got a lot, you have a lung infection, think of body positions. Again, we have another great talk that we had early on this year. Go back into our webinar series and look at bronchial hygiene. One of our physiotherapists talked on it, but you can position your body in certain ways to help get the mucus up. Or we have certain devices like the aerobica device, which is a valve that you breathe back and forth, and it helps loosen up that mucus so you can cough it out. So if you find that you have a lot of mucus and sometimes you may not have a hard time getting it out, you can get a device. I actually have one here to show you that you breathe back and forth, and it just helps shake the lungs up to get it, the mucus up and out.
I've used it, and when you breathe on it, you feel like your chest is going like this. We do this with babies all the time. We pat their back and we
just
help
helps
shake them.
Shake it out. So if you're someone that has quite a bit of mucus, these devices are really great at kind of helping you get that mucus out, but we don't want to stop the mucus, like Lindsay mentioned.
And mucus clearance will be improved if the mucus is thin. I use this example in my class and it grosses everybody out. But has anybody ever coughed up mucus and spit it into the sink and then tried to flush it down the sink? It stays like an oyster. It's this own little goober, if you will. That's my medical term. So we cannot add moisture or water to mucus that we've coughed out. But if we are hydrated, so we're drinking enough water, then the mucus can be thinner and then it can be easier to cough and clear. Okay, so that is so important that when we are sick, all we want to do is lay in bed and not feel well. We need to drink our fluids. We tell everybody this as we are parents or aunts and uncles or siblings, like drink your water. We always forget it, especially for the worst patients.
Hydrate and move around. The more we move around, the more we're going to get that mucus up and out. If we stay in bed and we let that bacteria fester. So just the simple of just moving around and body positioning is going to really help get that mucus out.
I hope that answered the question. Adam had another question about using expectorants when one develops a cold or flu with COPD. So as I mentioned, a viral infection will not generate mucus production. It's the bacterial infection and then the immune system fighting the bacteria and like all the dead bodies of the bacteria and then our immune cells and all that lovely stuff. If you're already coughing effectively, you don't need an expectorant. An expectorant is something that's just going to irritate your lungs and make you cough out more. And we don't want to irritate the lungs if they're already irritated. If you find that you do have a lot of thick mucus down there and your physician, so whoever your health provider is, they could recommend the use of an expectorant. And usually what we use is hypertonic saline. So normal saline is 0.9%. You can use a 3 to 7%. It has to be aerosolized in a neb and you breathe it in and it should irritate the airways to help you cough and clear. This is not something that you should go purchase and source on your own because it is irritating to the airways. You don't want to put yourself into a spot where all of a sudden you're in a coughing fit, especially if you have an asthmatic component. But if you find that you're having a hard time coughing stuff up, want to try the non-pharmacologic approaches first. Mobility, postural drainage, humidification, the aerobica device to help shake it off the airways before you even go and try medications or an expectorant, okay? Whenever, and my pharmacist is so good, he's always like, Lindsay, do you need another medication? I'm like, no, I don't. So we want to try and decrease what we're on, so we put less strain on. Really good question. And Alan, thank you so much. The aerobica is great.
And for those of you that are interested in it, Costco is the cheapest place to purchase it. You do not need a Costco membership to use their pharmacy, but it is one of the cheapest. And then I think Walmart was the next closest. So just know that different pharmacies unfortunately have different costs associated with that, but those were once sourced were probably the best places to buy them because they do range around $80, but I believe Costco is just a little bit cheaper, $90.
And they're so effective, and you don't need to use it all the time. If you find that you're having difficulty clearing when you have a bacterial infection, of course, use it. But if you are like Steph showing off, doing her 7K every day, yeah, thanks, Steph. just a reminder that I should go out for a walk, then you don't need to add that to your routine.
Yeah.
Okay, I know we're running over a little bit. But like, so raise patience. Are there any other questions before we say have a great summer and we'll see you in the fall?
All right.
Or you can just tell us how much you love us. No.
I will also be available all summer on the the Better Breathers Facebook page. So if you do have any other extra or any burning questions after this, or anything comes up throughout the summer, I do check that page at least once a week. So go on there. You can either private message me or just post it on there, and I go through and I try to look for any respiratory questions. So hope everyone has a wonderful summer, and keep your eyes out for our registration for when we are about to take registrations for our September talk on September 17th.
And I'm just going to add one more thought. We always start planning next year's series. So if there are presentations you've seen that you really loved and you'd love to see it again,
Let us know.
let Alexa know. You can contact her that way. Or if you have new ideas, we're always open to sourcing new topics for our group and see what they might want to learn about. Absolutely. Okay. Thanks, everybody.
Thank you. Have a
Have a
wonderful
Thank
great
you.
summer.
Thank you.
Have a great one.